Chairman-elect Dr. Rajshekhar Jaka, and all my vibrant EC members, Dr. Shilpa, Dr. Preeti, Dr. Anand Ravi, and Dr. Savita. Thank you all for joining today, and all the esteemed KSCSI members and the students. At the outset, I would like to thank Dr. Shilpa and Dr. Nagraj Bhalki for arranging this program. And we have our examiners, Dr. Ishwar R Hosamani, who is the director of KMCRI, and he's also the national EC member. Dr. Abdul Basheer, he's the head of the Department of Surgery at KBNU, that is Khaja Bande Nawaz University. And we have our very popular and senior teacher, Dr. Sharad M Tanga. And all of you must be aware of his social media posts, which are very encouraging and interesting too. So if you haven't, I think you should start following him. Then we express our gratitude to all three of you for accepting this invitation. And then, yeah, we have two students, Dr. Jyothi US from KMCRI and Dr. Sushmitha Bommanal from KBNU. I wish you both the very best of luck, and I'm sure it is going to be a very interactive session. Thank you all, and over to you, Dr. Sarvish.
Now, I request our moderators, Dr. Shilpa Huchannanavar and Dr. Nagraj Bhalki, to proceed with the program. Dr. Shilpa, please.
Thank you, sir. At the outset, I would like to thank our chairman, Dr. Nas, and our secretary, Dr. Sarve, sir, for giving us this opportunity for me and Dr. Bhalki, sir, to moderate this session today. And the introduction is also already given by Dr. Nas, madam, of our esteemed examiners. I would especially want to thank Dr. Ishwar R Hosamani, sir. In spite of his such busy schedule, he's agreed to become the examiner for today's session. And our very respected sir, Dr. Sharad Tanga, for giving us this opportunity to listen to him today. And I also welcome and thank Dr. Basheer, sir, for being the examiner for today's function. So without much delay, I would like to call upon the first presenter, Dr. Jyothi, a postgraduate from KMCRI, to present her first case presentation. I will take the permission of the examiners to go ahead.
Thank you.
Good evening to all the faculties present here. I'll be presenting a case under the guidance of Dr. Ishwar R Hosamani, sir, Director, Professor, and Head of the Department of General Surgery, KMCRI, Hubballi. Myself, Dr. Jyothi US, third year postgraduate student, KMCRI, Hubballi. Coming to the case presentation, here is a 71-year-old male patient by name S. He is hailing from Uttar Kannada.
Your slides are not visible, ma'am.
Share the screen.
Jyothi, you have to share your slides, please.
So here is a 71-year-old male patient by name S. He is hailing from Uttar Kannada, Karnataka. He is a barber by occupation. He came with a chief complaint of ulcer over the inner aspect of the left cheek since 3 months. Coming to the history of presenting illness, patient was apparently all right 3 months ago when he noticed ulcer over the inner aspect of the left cheek, which was insidious in onset. Initially, it was a size of 1 × 1 centimeter, and over a period of 3 months, rapidly progressed to the current size of 4 × 3 centimeter, involving whole of the inner aspect of the left cheek and extending to the left commissure. Initially, it was painless. From last 2 months, it is associated with burning type of pain, which is non-radiating, which aggravates on taking spicy food. It relieves on taking medications. History of difficulty in opening mouth since 2 months. No history of trauma from the sharp tooth, illness. No history of bleeding from the ulcer. No history of cough. No history of fever. history of halitosis, no history of ear pain, no history of excessive salivation and drooling of saliva, no
Dr.
history of
Jyothi, you should
difficulty in swallowing, chewing.
just 1 minute. Jyothi, you have to put forward your slides also. There's only one slide which can be seen. The subsequent slides you should start sharing. Yeah. Yeah, continue, please. Please continue, Jyothi.
Yes, ma'am. No history of swelling in the neck, no history of loss of appetite, no history of dyspnea, hemoptysis, weight loss, abdomen pain, and jaundice. Coming to the past history, patient does not have any comorbidities. Patient does not have any comorbidities, no history of exposure to the radiation in the past.
Next slide.
No-
Next slide.
Dr. Jyothi, if you have issues with synchronizing, you can keep it on the panel next there, and then we can always guide you. We don't know which slide you're posting. Okay,
Yes, sir.
okay, please go ahead.
Coming to the personal history, diet is mixed.
No,
Has a good appetite.
please go ahead.
Bowel and bladder is regular, sir. History of tobacco chewing in the form of quid since 40 years. 4 times in a day, and he used to keep it over the left buccal sulcus for around 15 minutes. History of alcohol intake since 40 years, and the last binge was 1 week ago, sir. Shall I summarize, sir?
You are finished with your history?
Yes, sir.
Okay. I would suggest that you can go ahead. I will come at the end of the examination, unless someone else wants to intervene.
Yes, sir.
Please go ahead.
Summary. Here is 71-year-old male patient who is a tobacco chewer and a chronic alcoholic. He presented with ulcer over the inner aspect of the left cheek, which is extending up to the left commissure, which was insidious in onset. Initially, it was a size of 1 × 1 centimeter, rapidly progressed to the current size of 4 × 3 centimeter. It is associated with burning type of pain. It is non-radiating and history of difficulty in opening mouth and with swelling in the neck. General physical exam.
If I had to intervene,
Patient is afebrile. Pulse rate is 8.
Dr. Jyothi, you told about the
Yes, sir.
lesion of the size of 1 centimeter into 1 centimeter when it was noticed. And within a
Yes, sir.
period of 1 month or 3 months? 3 months, right? 3 months it,
Yes, sir. Over a period of 3 months.
yeah, it progressed to 4 into 3 centimeters. What do you make out of it?
Sir, from this I could make like the ulcer is aggressive, sir. It could be malignant.
Okay. So the rate of growth is high and it is likely to be an aggressive tumor or aggressive lesion.
Yes,
Okay.
sir.
Fine. Go ahead, please. Go with the examination.
Yes, sir. Coming to the general physical examination, patient is afebrile. Pulse rate is 88 beats per minute, measured in the left radial artery. Blood pressure is 130 by 80 millimeter mercury in the left arm in a sitting position. Saturation is 96%, a true male. BMI is 20.8. ECOG score is 0, sir. No pallor, no cyanosis, no clotting, no generalized lymphadenopathy or edema.
Okay.
Coming to the local examination on inspection. Face is asymmetrical. Fullness is noted over the left cheek. No inflammatory signs present over the left cheek. Mouth opening is inadequate. All teeth are tobacco stained. Halitosis is present. Solitary ulceroproliferative growth, which is noted of measuring approximately 5 cross 4 centimeter. Anteriorly, it extends up to the left commissure and posteriorly extend 2 centimeter anterior to the retromolar trigon, and superiorly and inferiorly it involves the gingivo-buccal sulcus. Ulcer has an irregular margin, everted edge, and floor is filled with slough. Rest of the oral cavity mucosa is tobacco stained. Floor of the mouth is normal. Hard palate is normal. Upper jaw, all the teeth are present, sir. In the lower jaw, on the left lower quadrant, the first two incisor is absent, and the first molar is not there, sir. And in the right lower jaw, the first incisor is not there, and the last molar is not there, sir. It is age-related fall, sir. No swelling on the either side of the neck and supraclavicular fossa.
Why do you say
Coming
it
to
is
palpation.
age-related? How do you come to the conclusion that it
Sir,
is a... Yes, please.
Sir, it is if it is because of malignancy, then the soon after the fall of the teeth, the gingiva would have not closed, sir. The gum.
Okay. So you have the...
Which malignancy loosening of the teeth is more often seen? Jyothi, am I audible?
Yes, you're
Yes, sir,
audible,
you
sir.
are audible.
Okay. His question to the Jyothi, she said about the loosening of the teeth is related. It has been followed. She has mentioned about that. What is the importance of recent fall of teeth in the case of oral malignancy?
Dr. Jyothi, please answer the question.
Probably she's not audible, I think.
Dr.
Dr.
Jyothi?
Jyothi, are you hearing us?
Martin, look at it.
Dr. Jyothi is there, sir, but I think so she has internet issues.
Yes, yes. What is there to help us?
There is some internet issue, sir.
Okay, no problem.
She'll get back in 2 minutes.
Yeah, no signal is seen in first station.
Shall we go to the second presenter and then come back to her?
Fine, fair enough, madam.
Yeah, we'll get to later.
Okay, I think that should be okay, madam. If it's not getting resolved, then I will just...
Yeah, there. Yeah.
Dr. Jyothi has joined and sharing the screen.
Fine.
Yes.
Okay. Continue, please.
Coming to the palpation, sir.
Dr.
Ishwar
Yes,
sir,
sir.
just ask one question. I don't know whether you could be able to hear him or not. Which
Yes, sir.
malignancy the tooths are more often they are loosening? That was the question, I think, Ishwar sir.
Yes.
Yes, sir.
History of loosening of the teeth and falling of the teeth.
Yes, sir. Sir, that means, sir,
Are you aware about this?
Yes, sir.
Yes, continue.
Dr. Jyothi, I have two comments to make. One, it is preferable that you, in examination, don't infer as far as
Yes.
possible. Tell what is your finding out of it. Then at the end, you can infer it. For example, you say the tooth fall was because of, you believe it is age related. So you say that the tooth is absent and the gum is covered. So that will be the better way of presentation.
Yes, sir. Yes.
The second thing is try to be specific as far as possible. For example, in a lesion like this, in buccal mucous membrane, we are suspecting a case
Yes,
of
sir.
malignancy. You say that no swelling in the neck.
Yes, sir.
We at postgraduate level, we would expect you to be specific. What swellings you are expecting in the lymph node in the neck, and then rather tell that whether they are present or absent on history. An examination will go ahead again and again.
Yes.
Right?
Yes, sir.
Rather than being vague.
Yes.
Please go ahead.
Yes. Coming to palpation, inspector findings are confirmed. No local rise of temperature. Tenderness is present. Ulceroproliferative growth noted on the inner aspect of the left cheek, measuring 5 cross 4 centimeter.
This is Dr. Jyothi.
Yes,
At
sir.
postgraduate level, this order sequence is not desirable. Inspector findings are confirmed.
Yes, sir.
The first thing you would look for is temperature, tenderness, and then go to the confirmation of it.
Yes, sir. Yes.
Okay.
Yes.
Fine.
Ulceroproliferative growth noted inner aspect of the left cheek, measuring 5 cross 4 centimeter. Posteriorly, it lies 2 centimeter anterior to the retromolar trigon, superiorly and inferiorly involving the gingiva buccal sulcus, and anteriorly it extends, involving the left commissure. Induration is present, which extends 0.5 centimeter from the margin. Base is firm and non-mobile. Mucosa is fixed to the mandible on bidigital examination. It does not bleed on touch. No sharp tooth present. No loosening of tooth present. Skin over the cheek is pinchable. Next, neck examination. Swelling of 2 cross 2 centimeter noted in the left submandibular region, which is non-tender and non-mobile, and it is fixed, sir. It is a level 1 submandibular lymphadenopathy is present, sir. Systemic examination is normal.
When you have a submandibular swelling.
Yes, sir.
In this instance, you would tend to go for a lymph node. But
yes, sir.
Is there any scope for any other examination you would like to do?
Any other?
In the submandibular fossa, if you happen to see some more swelling there, sir, I want to ask, any further examination you would like to do it or not?
Yes, sir. I would like to examine the floor of the mouth, sir.
For what?
To look for any other primary lesions, sir.
Oh, no. That's not nice.
Would you like to do bidigital examination?
Bidigital examination.
Okay. So a swelling like that, specifically, it is desirable that you add to it. Okay.
Yes, sir.
Without doing that, you cannot jump to the conclusion that it is a lymph node.
Okay.
Though the possibility is high because of the primary lesion.
Yes, sir.
Okay.
Sir is expecting any swelling in the submandibular fossa, one should always do bidigital. You need to differentiate whether it is submandibular lymph node or whether it is submandibular cell adenitis. So that is the reason sir is asking this question. The moment you mention that submandibular swelling, then you have to always mention about the bidigital palpation. If it is a bidigital palpation, it diagnosis something different. Okay?
Yes, sir.
Is there any comment about the mandible?
Yes, sir. The mucosa is not freely mobile, sir, over the mandible on bidigital examination. It is fixed, like it is infiltrating the mandible, sir.
So there is a thickening of the mandible. You are not able to feel the mandible.
Yes, sir. Yes, sir.
Okay, is there any extent for it? Is there any extension, the involvement of the mandible till where
No,
to
sir.
where it is appears to be?
It is involving upper this alveolar, sir.
Okay. Not in the
Upper part
lower
of the
part.
mandible.
Okay.
Systemic examination is normal. Coming to the summary, sir.
It's,
71.
I think it's all right. I have few things to ask here. Now, in the presentation, what is important with respect to the location of the intraoral growth? You say it is from left commissure, extending 2 centimeters with, before the retromolar area. What is the clinical significance of this?
Sir, if it is it is extending 2 centimeter anterior to the retromolar, means if at all it is retromolar trigon is involved, it will become T4B and it will become unresectable, sir.
So here it is not involved.
It is not involved, sir.
Okay. So that is the reason. So you have a clear thing that the retromolar area is clinically free.
Yes, sir.
And it is involving the commissure.
Yes, sir. Left commissure.
Left commissure. So what is the significance of it? Clinically, how does it make any difference for us?
Sir, most of the like left commissure, this ulcer or anything will behave like a lip carcinoma, sir. One thing.
Okay.
And second thing is it is a primary extension of the primary tumors are there.
The spread,
So left commissure.
Okay, go ahead. Go ahead. Okay, I will leave it there. The drainage would differ, right? Once you go to the commissure area, the draining area would differ. That's one aspect of it. Surgically, it matters. The next important thing is the extent. Dr. Basheer was trying to ask you, would you tell us whether the gingivobuccal fold, the teeth on the lower aspect and the upper aspect, both, they are free, and what is the clinical significance of it?
Sir, if it is lower gingivobuccal sulcus and the upper, if it is free, then it not that means it indicates clinically that mandible is not involved, sir. And surgically, there is no need of doing mandibulectomy.
It's one of the things, not all.
Yes,
you know, that
yes, sir.
doesn't mean. So one of the things. So here the upper gingivobuccal fold is free.
It is free, sir.
It is free. The lower one?
Lower one is it is not free, sir.
Fine. With respect to the oral opening.
Yes, sir.
You never commented. You just said difficulty in opening.
Yes, sir.
Is there any criteria? Is there any judgment? And why is it occurring here?
Sir, one thing in this case, the patient is unable to open the mouth inadequately. It could be because of the one thing is commissure is involved, sir. Left commissure is involved. Second thing, it is infiltrating to the deeper structure, sir. That is muscle, buccinator muscle.
How do you say that?
And one more thing, sir. As the patient is a tobacco chewer and a chronic alcoholic, the other condition could be oral submucosal fibrosis, sir.
Dr. Jyothi.
Yes, sir.
You are speculating. We are talking about this case. In this case, what is the clinical finding which will tell you that the difficulty or inadequate opening of the oral cavity is because of so and so?
No, in this case, what could be the reason? Sir is asking, in this case, what could be the reason?
Involvement of mastication muscle, sir, and the left commissure is a possibility.
Which masticator muscle we are talking here now?
Buccinator muscle, sir.
Does buccinator muscles interface with the mouth opening?
No, it does not, sir. But sir, it could be like a posterior extension of the lesion, sir.
Yeah, in this case, probably the reason is probably extending posteriorly. That would be the one reasons.
Yes, sir.
Buccinator per se will not take part anything in the mouth opening, as far as I know. It is involved in the anterior commissure of the angle of the mouth is involved. Probably that could be the reason in this case. Or it could be posterior extension nearer to the retromolar trigon, that also
Right.
contributes for the limited opening of the mouth. Then categorically, he was telling about submucous fibrosis because you have mentioned the rest of the oral cavity is normal. So do you think that is ulcer is the secondary to the pre-existing conditions we had, or it is a de novo?
It is de novo, sir. It is de novo.
In that case, remaining part of the oral cavity could have been normal.
Yes, sir.
Yes. Okay.
That is very
Just to
important.
be specific, like you mentioned about the
Please go ahead, Dr.
tobacco
Basheer.
chewing part, that's four times per day, and 15 minutes duration.
Yes.
What is the significance of it?
As the number, as the hours of intact of this quid with the mucosa increases, sir, the risk of developing carcinoma buccal mucosa, it increases, sir.
Can you tell me what is the chemical composition of quid?
Yes, sir. So it contain quid is composed of areca nut, bitter leaf, tobacco, and slaked lime, sir. That is calcium hydroxide. So all these components, one thing, areca nut, it produces arecolin, sir, and tennis, which produces more of collagen synthesis, and tennis stabilizes the collagen, sir, and calcium hydroxide, which makes the alkaline pH, sir, which increases the permeability of this substance into the mucosa and also causes micro ulceration, sir. So as the duration of the intact of this substance in the mucosa increases, the chance of developing any ulcer or the carcinoma is more it's at high risk, sir.
History of sleeping with the quid in the mouth. Is there any relevance for it?
Yes, sir. In this case, the patient is keeping in the left sulcus, sir, for around 15 minutes, sir.
Alcohol history you said about like chronic alcoholic. Like,
yes,
is there any importance like to be specifically add amount of alcohol he was taking and the duration of alcohol he was on?
Not specific, sir, but he's a chronic alcoholic.
Since he is an alcoholic for the past 40 years, in any way, this is contributing for his etiological ulcer.
Yes, sir, it is, sir. It is.
How?
Not directly, sir, but it is a synergistic. It has a synergistic effect, sir.
Yes, exactly. It is an additive effect. The proper word is it has an additive effect for his all carcinogenic agents. Okay.
Yes, sir.
What is the definition of the cheek? May I ask the simple question?
Yes, sir. I didn't get you, sir. Sorry.
What is the anatomical definition of cheek? Simple, basic question.
Cheek with.
It has got dimensions, no? It has got dimensions.
It has a dimension, sir.
Yes, yes. Tell me now, what is anatomical?
Anteriorly from the commissure till the retromolar trigon, sir, above to the zygoma and below to the mandible, sir.
Not zygoma, not zygoma, not zygoma, not zygoma. Zygoma is exteriorly. How it can be there? Anteriorly, what is said is right. From the angle of the mouth commissure to the retromolar trigon, anterior posteriorly. Okay, one dimensions. Any other dimensions?
Cheekbone, sir. It could be
above and below. Can you mark the anatomical?
Above up to the maxilla, sir.
Not maxilla. This proper word is there. Proper word is there.
Is it zygomatic arch?
Not zygomatic. Zygomatic comes exteriorly.
Okay.
It is upper alveolar buccal sulcus of the maxilla, superiorly, inferiorly from the mandibular sulcus.
Yes.
These are the superior and inferior limits. Anteriorly, commissure to the retromolar trigon. This is the exact area of definition of the cheek.
Yes, sir.
Okay, sir, continue, please.
Dr. Jyothi, we will complete this part. There is a reason for me to stress on those two important things. One, tumor, all you explained, lymph node, a bit detail would have been better. Third important thing for you to concentrate on history and examination would have been to talk about oral opening. How much is the opening? What is the normal opening? There is a dimension for it. We will not go into that part. So that is one thing that will give you the involvement of the deeper structures.
Yes, sir.
And why it is significant, we probably will see later. Why oral opening is important for us. Third thing is the mandibular involvement.
Yes,
so
sir.
I want you to concentrate on these four things when you are going to investigation.
Yes, sir.
Please go ahead.
Coming
Skip
Summarizing.
this. No.
So we
skip.
have another 5 minutes for the presenter.
Yeah, that's what. We'll skip this part.
Yes, sir. Sir, my diagnosis is carcinoma left buccal mucosa, stage 4A, T4A, N1M0, sir.
Okay.
If
Go
the
ahead.
skin is involved, does the stage would have been differ here?
No, sir. Skin involvement will not change the staging, sir.
Yes, good. If the skin is involved, what will happen next? What is the further progression of the disease, natural history of the disease?
It will lead to the fistula, sir. Sinus
Okay.
and then fistula.
That's called as?
Orocutaneous fistula.
Orocutaneous fistula. Okay, fine. Okay. Continue.
Go ahead.
Sir, yes, sir. Sir, I would like to first confirm my diagnosis, sir, with histopathological examination, that is incisional biopsy.
Okay, you are done. What is the important point? Just read out. I don't want whole of it.
Yes, sir.
It's squamous cell carcinoma.
Yes, sir. It is a squamous cell carcinoma, sir.
Okay. Grading?
Grading, they have, it is not mentioned, sir.
Not mentioned.
Yes.
Okay. Then go ahead. Go ahead.
This is a
CT
CT
scan.
neck and chest, sir.
Okay.
What is the reason for asking for chest CT in this case?
Sir, as a carcinoma buccal mucosa is not restricted only to the oral cavity, sir. It is a complete, as a patient is a tobacco chewer or the alcoholic, it involves a complete aerodigestive tract, sir. So it is like a field cancerization to rule out other primary lesions,
I
sir.
think
So
that's not. I also would go with Dr. Hosamani, right? He raised that issue because of you being a student also. Please, that I think is a CT scan of the oral cavity and neck is what is preferred.
Yes, sir.
Okay. So what is that you are done about the oral cavity? What investigation you are done?
OPG we have to get it done, sir.
You have to yet to get it done. Okay.
Yes, sir.
Fine. You would like OPG first or CT scan? Which preferable? TCT of the oral cavity and neck?
Sir, I would like to first go ahead with the OPG, sir. As the mandible is in
mandible.
As the mandible is involved, sir. So
see, you have to be answered very specific. When you ask for a CT of the neck and oral cavity, the purpose of getting investigations must be very clear. Next, you're asking for the OPG. OPG is for some other reasons. CT neck and oral cavity for some other reasons.
CT
for the
neck.
staging purpose of the oral cavity, how far it is involved, though you are clinically mentioned that CT is good enough. For involvement of the mandate is always a OPG. Okay.
Yes, sir.
Because the bone window sometimes can be misleading in a CT. For the ideally, even though you have got a bony reconstruction facility, still then majority of the consultant asks for the OPG because it gives an entire length of the mandible, so they can have a better assessment.
Yes. CT neck and chest is for the staging of the tumor, sir.
Okay. I think you have anything to tell about this specifically?
Yes, sir. It shows the impression of the CT scan, irregular focal mucosal lesion of the left lower lip and gingival-buccal sulcus, sir. Neoplastic with erosion of the mandible, sir.
Okay.
This is the CT imaging finding, sir.
I will reiterate that two things. One, TCT of the oral cavity and neck should be able to comment on the mandible primarily. It should be able to comment on the neck, lymph nodes, and other structures. Okay.
Yes,
so that is the relevance of it.
Yes, sir.
Especially the cortical involvement. We go ahead with the next investigation, please.
Yes. We have another just 2 minutes. So,
yes, sir.
Dr. I am hurrying up. We'll just give us another 5 minutes of extensions.
Yes.
We will take it to the logical end. Otherwise, it will be incomplete. Please go
Well,
ahead.
speak for another 5 minutes for the management purpose, investigation management.
Yes,
Keep another 5 minutes.
I'm hurrying up. Please.
That's all, sir. this
Okay,
CT neck and histopathological examination to confirm my diagnosis, sir, and the rest of the investigation for the to making the patient fit for the surgery, sir.
Okay. So would you like to do MRI?
Yeah, sir. If it is like soft tissue, for the soft tissue definition, I would like to go ahead with the MRI, sir. If at all the perineural invasion is there or the soft tissue involvement, then MRI is the gold standard, sir.
Yes. In this case, probably MRI would have been ideally preferable to look for the soft tissue involvement,
Yes, sir.
because it requires an extensive resection. For that, you priorly will have what are the structures are involved. Contiguous structures involvement is very essential in this case. Ideally, MRI would have been preferable for in this case. For the nodal disease, definitely CT is the better. But since it is only one lymph node in the submandibular region, even MRI also will take care of it. MRI also would have been better for the soft tissue delineations.
Yes, sir.
Complementary. Yes, so MRI is always complementary over a CT scan.
Go ahead. You are finished, right? How
Yes,
will you
sir.
manage this patient? Give me the
Sir.
treatment aspect of it. Tell me the treatment
Sir,
aspect of it.
I would like to go ahead with the wide local excision with 1 centimeter surgical margin, sir, with the left hemimandibulectomy, with the elective neck dissection, with the reconstruction of the reconstruction with the PMC flap, with the mandible reconstruction, sir.
Okay.
Jyothi, if the facilities are available, can
Yes,
you plan
sir.
something else for them for the better cosmetic purposes and other things?
Yes, sir. We can plan like implants, sir. We can go ahead with the implants, sir.
Anything better than which can use his normal structures, which can give a better results?
We can use the fibula, ribs, corticocancellous bone of the from the iliac crest can be used, sir.
Is there any limiting factor in this case? Ideally, what you said is absolutely right. All the reconstruction has to be biological reconstructions, first and foremost. That gives the
Yes,
better
sir.
aesthetically, it is better. You can have the microvascular fibular
Microvascular
reconstruction,
hospital.
which takes care of
Yes,
the
sir.
bone, and then remaining part it will be taken care, because you are going to excise part of the skin also in this case, because it's almost
Yes, sir.
impinging to the. You cannot save the skin in this patient. You are going for a wide local excision. Since mandible is also involved, probably you may have to. It is not a marginal. It is inner table is also involved. So probably you may go
Yes,
for
sir.
the hemimandibulectomy that can be
Yes, sir.
reconstructed by fibular reconstruction. The ideal scenario. Is there any limiting factor in this patient?
Yes, sir. As the patient is elderly, sir, so they'll most of the time they'll be having atherosclerotic changes in the blood vessels. So, yeah, for such elderly patient, the titanium plating implant is best, sir. I would like to.
Yeah, what you said is right, because it's very elderly, 71 years old. The vascular status is sometimes will be risky in these cases, atherosclerotics and other things. However, precautions we take, chances of flap rejection is pretty high in these patients. So elderly patient looking into his age also, and then it is a too morbid procedure and lengthy procedure, you may not able to withstand also. I think better
Yes,
is
sir.
you can just reconstruct the mandible with either the titanium implants. It is good enough, it will not take much time, and then you can cover the defect with the pec major flaps with the neck dissections. Which neck dissection you would like to have in this patient?
Sir, I would like to have selective neck dissection, that is anterolateral neck dissection, that is suprahomovoid neck dissection. I can go ahead with this, sir. As only level 1 lymphadenopathy is present.
Yes, since it is a buccal mucosa, it is not as aggressive as the remaining part of the
Yes,
oral
sir.
cavity lesions. I think extended supraarm and neck dissection is probably for the staging purposes good enough in these patients.
Yes.
Any
I'm
adjuvant
done.
therapy? Any adjuvant therapy you would like to consider for this patient, or is it the
Yes,
end of
sir.
the?
Yes, sir. Based on the pathological, histopathological examination finding, as I also told that it is a stage 4A, sir. So in such case, the patient has to go and has to undergo adjuvant chemoradiotherapy, sir. And
Yes.
other criteria which depends on that, like stage 4, stage 3 and 4. And if the margin is positive, sir, or the margin is less than 0.5 centimeter, or more than 2 lymphadenopathy is present, or extracapsular involvement is there, or perineural involvement, lymphovascular involvement, in such all cases, we can go ahead with the chemoradiotherapy, sir.
Yes, exactly right. If these are the parameters which it considers when you are planning for, otherwise also they require, and these features are there, it becomes much more mandatory to consider the radiotherapy
Yes, sir.
as an adjuvant therapy in these patients.
We're done, I think.
Thank you, Dr. Jyothi, for the
Thank you, sir.
presentation.
Thank you.
Okay, I would like to call the next presenter, Dr. Sushmitha Bommanal, to start her presentation, please. Dr. Sushmitha is a postgraduate from Khaja Bande Nawaz University, Kalburgi.
Good evening, teachers. Myself, Sushmitha. I am surgery resident from KBNU-FOMS. I am presenting this case under the guidance of Faculty Department of Surgery, KBNU-FOMS.
Ma'am, you can go for full screen mode, ma'am. It's in the bottom left, ma'am. Right now. Yes, ma'am. Yes.
I am presenting a case of 61 years female, farmer by occupation, hailing from Bidar, came with complaints of lump in the left breast since 9 months. Patient was apparently all right 9 months back. Then she noticed a lump in left breast, gradually progressive in nature. Initially, it was of the size 4 into 3 centimeters, and now it progressed to present size of approximately 8 into 6 centimeters. There was no history of sudden increase in size, no history of pain in the lump, no history of fever. There is no history of nipple discharge. There is no history of swellings in the left axilla and left supraclavicular region. There are no other swellings anywhere else in the body and opposite breast and axilla or in the neck. There is no history suggestive of metastasis like dyspnea, chest pain, jaundice, back and bone pain. No history of loss of appetite or loss of weight. Past history, she is a known case of hypertension since 3 years on treatment. Known case of diabetes since 3 years on treatment, and she underwent tubectomy 25 years back. There is no history of previous breast or ovarian surgery. Personal history, diet is mixed, appetite is good, bowel and bladder is normal and regular. There is no history of alcohol consumption. Menstrual history, she attained menarche at 11 years of age with regular cycles of 5 days with adequate flow. She underwent menopause at 42 years, 19 years back. Obstetric history, she is married at 12 years, para 5, living 5 and abortion 0. First child was born at 13 years. Includes 3 daughters and 2 males. All children adequately breastfed. 2 years gap between each childbirth. Family history, there is no suggestive history of breast ovarian cancer history in the family. General physical examination. Patient was examined in adequate daylight with proper consent. She is well built and moderately nourished with BMI 21. Afebrile, pulse is 86 beats per minute, right radial artery, normal rhythm, regular volume. Blood pressure 140 by 80 mm Hg, right arm supine position. Respiratory rate is 16 cycles per minute. There is axillary lymph node enlargement. I will discuss this in lymph node examination. There is no pallor, icterus, cyanosis, clubbing or edema. Inspection with informed consent after adequate exposure with positions by the side of the patient in sitting position, arms above the shoulder, bending forward position and supine position. I had examined the patient. Right breast, right side breast and axilla is normal. Symmetry, left breast appears larger than right breast. There is fullness in the upper outer quadrant, upper inner quadrant, lower quadrant of the left breast. Skin over the breast is stretched. There is dilated vein seen in the upper outer quadrant of the breast. Nipple areola complex is normal and there is no discharge. Axilla and arm is normal. Supraclavicular fossa is normal. Right breast is normal. Left breast palpation, there is no local rise of temperature or tenderness. A solitary lump of 9 into 7 centimeters in upper outer quadrant, inner quadrant, central quadrant, lower outer quadrant is present. Lump is uneven surface, ill-defined margin, hard in consistency. Skin over the lump is free, moves with breast but not independent of breast. The lump is not fixed to the underlying muscles or the chest wall. The nipple areola complex is normal. Lymph node examination, single lymph node of 2 centimeters, mobile and non-tender, firm in consistency in the central group of left axillary lymph nodes is present. No lymph nodes palpable in the left supraclavicular fossa. Systemic examination, respiratory system, normal vesicular breath sounds are heard, no added sounds. Per abdomen, soft, non-tender, no organomegaly, not distended, no free fluid. Per vaginal and per rectal examination, there is no clinical abnormality detected. Examination of spine, no spine tenderness and no deformities noted. Summary of my case, 61 years old postmenopausal female with 9 into 7 centimeter sized swelling in the left breast, 9 months duration. There is no skin or chest wall involvement. Single central lymph node is palpable. Probably carcinoma of left breast. Clinical stage is T3N1M0 stage 3A.
Hold on. The history part was after the completion of history. What you infer from the history part?
Sir, first
Just
of all,
only the history without examining the patient. The history,
yes.
what you have taken. What was your inference at that time?
Sir, I'll consider her age, and the lump is slowly progressive. It is for long duration. So, and considering her age, I'll go for one of my differential diagnosis will be carcinoma only.
Why do you think so? The
Sir,
size wise you mentioned is around 9 and 7 centimeter developed over a period of 9 months. Okay. Do you expect such a large lesion will happen in malignancies? Without being skin involved, without being complaints of that?
No, sir. Phyllodes is one of the differentials for this diagnosis.
Such large lesions are there, 9 centimeter
Yes.
large lesions involving the more than 50% of the breast with no retraction. Even though the lesion is there in the breast area, the nipple areolar complex is still there on examinations, and such a large lesion is there, then you have to keep the possibilities. I know that any breast lump has to be malignant until proved otherwise. But looking at the history, 9 such a large lump. So you have to still consider the phyllodes tumor. Does age is favorable for phyllodes tumor?
Sir, usually phyllodes occurs in the age group 40 to 50 years. There are chances, 10% chances for phyllodes in this age group.
Yes, still in the history level, such a large lesions is that developed over a period of 9 months. Even though she is elderly, you have to keep the possibility of the other this tumor also. Until examination, other things probably you may rule it out. That is a different story. But in the history level, you have to mention about that. You have to keep that possibility also. Keep that possibility also. One more important things you have not done in this patient. Can you recollect?
In examination.
You have not mentioned about the examination of the internal mammary lymph nodes in this case. You have mentioned about the axilla and you have mentioned about the supraclavicular fossa, but you have not mentioned about the clinical examinations method of looking for the internal mammary lymph nodes. How to look for?
Yes. Sir, there is no parasternal dullness or fullness noted.
Which space?
Second, third, fourth.
Second and third space. Okay. So why they are called as internal mammary nodes?
They are present.
All along intrathoracic or extrathoracic?
Intrathoracic.
They are intrathoracic all along the internal mammary veins. That's why they are called the internal mammary lymph node. What is the percentage of involvement of the internal mammary lymph nodes?
Sir, 10%.
10%. Is it? Do you expect in this case more probability or less probability?
Sir, in this lump is seen in the inner quadrant also, sir. There might be,
More
majority of it is outside.
Predominantly, it is an outer quadrant.
Predominantly, it is outer parts.
Extending onto that, but chances are still there because since it is involved in the inner quadrant also, upper quadrant tumors are less likely. Even though it is 10% statistical wise, upper quadrant tumor, outer quadrant tumors are less as compared to the inner upper and inner lower, inner upper and inner lower. So one should always mention it. Don't missing the not examination of the lymph nodes, draining lymph nodes is a crime in the case of breast lump. Okay. You are not written and you are not mentioned also. Probably you are forgotten, I think. Probably must have examined it, but you have forgotten it.
Yes.
Okay. What is the purpose of palpation of the opposite breast and opposite axilla?
Sir, there might be multicentric involvement of other breast also. So there is 10% chance of involvement of other.
Opposite breast.
By same internal mammary drainage, there might be involvement of opposite breast also, sir. Or patient might have a lump in the opposite breast, which she might not have complained of.
Okay, for the two reasons, one thing you have to mention. When such questions are asked, no, you have to say that there could be one more primary. Okay, one more primary in the breast, keeping the possibility of the bilateral breast carcinoma. That is, what is the percentage of bilateral breast carcinoma?
So 10 to 20%.
No, less. It is around 3 to 5%, not 10%. 3 to 5% bilateral breast carcinoma. For that reason, you have to always mandatory to palpate the opposite breast and axilla, looking for the what could be bilateral. One reason. Another reason, could it be metastatic? Could it be with the intention of whether it could be metastatic breast lump in the opposite? For that reason, you need to examine the opposite breast and the axillas. Okay.
Just how do you differentiate pathologically or clinically the synchronous or metastatic lymph node? metastatic breast in the other breast?
Sir, synchronous lesions appear within 6 months of the primary lesion, sir. Metachronous appears after 6 months of the primary lesions.
No, synchronous or metastatic.
If they appears after 6 months, they should be called as a metachronous. And
Metachronous.
definition is this way, not that.
Yes.
Okay, if the tumor appears beyond the 6 month, then you have to consider. Then within the vicinity of the tumor, if it appears, so that is
It
one
is a
definition.
synchronous. Yes.
Synchronous. Okay.
In examination, is there any changes you found in the nipple areola complex?
Sir, there were no changes, sir. No changes in nipple areola complex.
Okay.
Okay. Does it fall forwards in this case? This particular case?
Yes, it fall forwards.
What is the inference of breast
Sir,
falling
no
forward?
chest wall involvement. It suggests there is no chest wall involvement.
Generally, normally, breast falls forwards.
Yes.
Okay. If it doesn't fall forwards, it indicates that it could be involved with the chest wall. Don't mention about the pec major muscles. You always particular about the chest wall. Okay.
Yes.
On raising the arms, what is your inference?
Sir, on raising the arms, the nipple areola complex slightly moves upwards and outwards. There is no dimpling, puckering, or retraction of nipple seams.
What are the advantages of being examination of this particular patient when the arms are raised above the head?
Sir, we can note down the skin changes.
Okay. Chin changes
We can note skin changes and
yes. Okay, then?
Inframammary region can be made out properly.
Very
And
good.
axilla can be made out.
Yes, in a large pendulous breast, when there is difficulty in accessing the lower quadrant of the breast, there can be better visualized when the arms are raised. And then look for axilla also. There's one more. Then anything else?
That's
Skin changes are better made
skin
out.
changes are better made out.
PD orange, puckering, all these things are better because when the arms are raised, skin stretches, no? So these skin changes are there, which are not evident. When you're examining when the arms are by the side, they are better appreciable when the arms are raised. Anything else? Arms, edema of the arms also can be better used. Once the raise both, no, you will have simultaneous to compare. So these are the one advantages when you examine the patient and the arms are raised above the shoulders. What are other positions which you need to examine the patient?
Bending forward, sir. Arms by the sides, supine position. Arms over the waist.
Then
in a relaxed and contracted positions.
Why the arms by the over the waist?
So to check for pectoralis major muscle involvement on relaxing.
What is the importance? Does it add to the stage?
So it doesn't add to the stage.
Then why you want to do it? If it doesn't alter the T stage, then why you want to do that?
To see if it is involved in case of
to
plan for surgeries. To plan the surgery.
Otherwise, also will plan the surgery, no? It gives certain amount of information to the surgeons when he is operating. If he feels so, the pec major is involved. When you are planning for the surgery, he will take out some of the superficial fibers or deeper fibers of the pec major muscles. That is the inference you are gathering, whether pectoralis major is involved or not involved. But it will not add on to the stage. T stage doesn't differ. Okay. Then which involvement of the breast makes the T stage difference?
So chest wall involvement, skin involvement.
Yes, very good, very good. Involvement of the yes, okay. In the history you have mentioned, very elaborative, detailed history you have taken. Okay. Yes. Coming to the menstrual history, which are the risk factors in this patient?
So early menarche, late menopause, nulliparity, late childbirth, lack of breastfeeding.
Okay. Which is the single most risk among all these things?
Nulliparities.
Nulliparities is the most risk. No.
Late childbirth, late first childbirth.
No. The single most risk factors is the age of the mother when the first child is born. It is considered highest risk factor compared to all the remains. All are contributing to the risk factors, no doubt about it. Among all these things, age of the mother and the first child is because from the onset of the menarche, it is totally unsuppressed.
Yes.
It may be 5 years, it may be 6 years, it may be 10 years. The remaining part also contributes to a certain extent. Amongst all these things, the single most risk factor is age of the mother as the first child is born. Okay.
Yes.
What is the importance of abortion? You specifically mentioned about the abortion. What is the importance of it?
Abortion is a risk factor for the CFRS. There is no progesterone, so only increase of estrogen.
No. That should not, that is not the answer. Suppose, how many children are this patient?
5 children.
How many miscarriages are there?
No miscarriages.
No miscarriages. If suppose some miscarriages are there, 2 or 3, 4 months duration, 3 months duration, is it beneficial to the patient or harmful for the patient?
It is harmful for the patient.
How it is harmful? So she's losing the child, that is okay, that is harmful for that. As far as the breast pathology is concerned,
There is only increase in estrogen.
that is the reason miscarriages occurs, because of the imbalance in the hormones. That is the answer for that. Even if the patient has got miscarriages of few month duration, of 2 months and 3 months durations, it is beneficial to the patient, because those periods for the pregnancy, 9 months is a protective factor or non-protective factor?
Protective factor.
Protective factor. And the 9 months is the protective factor. So few months, 3 or 4 months, why not be protective factor? Even if the number of miscarriages are there, it is going to add on to the beneficial for the patient. It is a loss of the child is okay. That is apart. I'm not talking about that. It becomes the one of the, because the patient has got a amenorrhea that time, no?
Yes.
That amenorrhea period, so estrogen is suppressed.
Yes.
It will add on to the benefits to the patient. Even if the number of miscarriages are there, 4 or 5 or 6, whatever it is, it will add on to the benefits to the patient. It is considered as pregnancy only.
Yes.
Only not full term. Less term.
Yes.
You got it, no? Okay.
Yes.
Then, so clinically you put it as a carcinoma, but stage
T3 N1 M0.
T3 N1 and
M0.
M0. Okay. T3 N1 and M0. Okay. How will you proceed?
So first triple assessment I would do, sir. Mammography.
In which disease you will do quadruple assessment?
In CA.
In which disease you will go for quadruple assessment? Triple assessment,
And
breast is exactly correct. Where is the quadruple assessment?
sir,
In
carcinoma of buccal cavity. With
buccal
unknown
cavity.
tumor.
In thyroid diseases. Which is the 4th quadrant there? Clinical, radiological, and pathological is acceptable. It is assessment. Sorry, triple assessment. Quadruple ಅಲ್ಲಿ thyroid ನಲ್ಲಿ ಯಾವ್ದು ಮಾಡ್ತೀರಾ? T3, T4, TSH. Thyroid profile is considered as one of the quadruple part of the thyroid. For the breast is a triple assessment. It's a gold standard. Okay. Then clinically you are done. What you will do next?
So mammography, sir. Then core needle biopsy.
Why? What is the need of mammography in this patient?
To check for other multifocal lesions, if any other lesions are there.
Okay.
In the other breast.
Okay. How it makes difference?
Sir, if the other breast is also involved, then we should see whether it is.
Management is totally different. We're talking about the only involved breast.
Yes. Then I would continue with core needle biopsy.
No. What is important is mammography in this patient? It is such a large palpable lesion. It is evident.
Yes, it will tell the features of carcinoma, sir.
Anybody could have make it as a possibility of a carcinoma. Still, why you want to do the mammography?
In other words, what is this LABC and what is this early breast cancer?
Sir, early breast cancer, there is no skin involvement. Stage 1, 2A, 2B are considered as early breast carcinoma, sir. LABC is late stages. If there is skin involvement or if the size of the tumor is big axillary lymph nodes involvement, chest wall involvement.
Does it change any line of management in these patients? Early breast cancer or LABCs?
Sir, in LABC, we prefer giving neoadjuvant chemotherapy, then downstage the tumor. Then if it becomes operable, then go for surgery.
There are 2 parts in LABC. One is
operable and inoperable. So
this comes in which condition? It comes in operable or inoperable LABCs?
It comes in size of the tumor is large compared to breast ratio, sir. It comes in operable.
If what is there any role for conserving the breast in this patient?
No role for conserving
the
breast.
What is the role of mammography in this patient?
Exactly. I'll come to the same point now.
Yes.
Sushmitha, when
Yes,
if somebody is asked you, clinician, the doctor asked, consultant is asked about what is the role of mammography in this patient, we all know that mammography come with an intention of a screening modalities initially, but nowadays it is not be considered as a part of the screening modality. It helps for the management purposes. Okay.
yes, yes,
Whenever you plan for see such cases, no, your idea has to be clear. What you exactly want to do, whether you would like to cure the disease or whether you palliate the disease.
yes,
Okay. When you are
yes,
thinking in terms of curing the disease, you have to think of all the options are available.
yes,
Mammography is intended to look for the remaining quadrant of the breast. Forget about the opposite breast. Opposite breast is mandatory.
yes,
Look in the similar changes are there. For example, what you said about the multicentrality, multifocality is much more important. It comes to when you're planning for the breast
breast
conservation. No,
conservation surgery. Yes,
so you have to look for the remaining quadrant of the breast. Look for is there any multicentricity. If that is there, case is there, then your intention is not to conserve the breast. Your intention is to take out the breast.
yes,
Got it? No, so
yes,
just mastectomy is not the answer for all the breast carcinoma. Even though
yes,
such a large 9 centimeter is there in these cases, skin is
yes,
free. Okay, following the neoadjuvant therapy, this tumor might downsize. It may shrink
yes,
significantly. Patient may not give consent for the mastectomy. You can still go ahead with the breast conservation in this
breast
patient
cancer.
to decide whether to go for the mammography and other thing. One thing. Second reason, when you plan for a neoadjuvant therapy, you assess the response to therapy. Okay.
Yes, sir.
If you have got a previous
Complete.
mammography picture about the size and other things, okay, so definitely you can compare with the pre and post of neoadjuvant, whether it is downsized. It is a more of the objective assessment whether the patient is responding to chemotherapy. For these reasons, again, you have to have a mammography, which is the best mode of investigations to look for the response to therapy. Mammography is one. Any other modality?
To response for therapies.
To look for the response to your therapy.
Um,
You have two sorts of assessment. One is subjective and another objectives. Okay.
yes,
So subjective is always, you also make, you are examined initially. Patient also says that after the therapy, the tumor has shrunk. This objective, you have to proper assessment. The ideal is the MRI,
yes,
not even the mammography. You can't store the films in a mammography. It is very difficult.
yes,
Okay. The MRI is the best modality to look for, assess the response to therapy.
yes,
Okay. It's called as mama print. Have you heard about mama print?
yes, sir.
Yeah. It is a video mammography. Many times it is called as. So these are the very mandatory when you are planning for this. It is one mammography. Any other investigations?
I would go for core needle biopsy for this case.
Yes, you have to go for the
Core
next one.
needle.
Part of the department is a core needle biopsy. Why not FNSC?
So FNAC will not tell, it has the disadvantages. It doesn't tell about whether it is invasive or intraductal carcinoma, or it won't tell about hormone status, receptor status.
Okay. So you don't want to do FNSC in all the cases then?
We can do so.
The advantages of a core needle over the FNSC. But still then when it comes to
FNAC.
pathological assessment, your answer has to begin with the FNSC because it has got certain advantages. It is a fast outpatient, gives immediate information regarding whether it is benign or a malignancies.
Yes.
Once it gives the impression that it is a malignant in nature, then you have to go for or it is equivocal. You cannot come to the conclusions by FNSC.
Yes.
Whether it is a phyllodes tumor or whether in this case, such a large lesion is there. The FNSC may not become, in such cases, the core needle becomes a much more mandatory. If FNSC is already gives as a malignancy, to look for any added advantages like an ERPR studies and other studies, you have to look for the core needle.
Core needle.
Okay. What is the gauge of the needle for core biopsy you will do?
Sir, 22 gauge.
22. What? Okay. What is the ideal FNSC?
FNAC is 22 gauge, sir. Core needle biopsy is 11 gauge.
What do you mean by the ideal FNSC? You understand my question, no?
Yes.
You should use the fine gauge needle, around 25-26 gauge needle, and then it should be preferably ultrasound guided, where the tissue yield can be better. Look for the most representative part of the tumor, probably a solid in nature. It should be minimum 6 to 10 passes. These are the ideal FNSC for that.
Yes.
Similarly, when you want to plan for the core needle, preferably it should be done the ultrasound guided so that you can have a proper representative specimens. Okay. Then what will you do next?
What metastasis workups, because it is T3 and
what is the indication of metastatic workup in this case? The indication. Of
Tumor
course,
cell.
metastatic workup is a mandatory for all the breast carcinoma. Exactly
Yes.
right. What is the indication in this patient?
Size of the tumor.
Yes, very good. T tumor is bigger.
Yes.
Higher the T stage, more the chances
More
of
the
micro.
chances of metastasis.
So it is one of the much more indicated in these cases. Look for the metastatic workup. What are the metastatic workup you would like to do?
Sir, CT thorax, CT abdomen, bone scans.
Why chest and chest, steady chest? What are you looking for?
Sir, lung metastasis sir, for CT thorax.
Which is the commonest
Any-
mode of what is the commonest mode of metastasis to the lung?
Hematogenous.
Commonest mode. In what mode it can present?
Dyspnea, chest pain, cough.
Dyspnea due to what?
Because of pleural irritations.
Yes, very good. The commonest mode of lung metastasis is in the form of a effusions.
Pleural. Yes.
Then next form of metastasis is in the form of a metastatic nodules in there. So in such cases, symptomatology differs. If it is an effusion, most of the time patient comes with a breathlessness. If there are metastatic foci in the lung, most of the common complaint is a cough, dry cough, irritating cough, or there could be streaks of hemoptysis. So it is a parenchymatous infiltrations. Okay. Then abdomen is also look for the liver metastasis. The complete workup is very necessary. Anything workup you would like to do apart from chest, CT, and abdomen?
Bone scans to look for bone metastasis.
One more indication in the case, because the largest stage is always better to look for is there any bony metastasis are there in this patient. Okay, you are done. Is there any positive findings in this case? Metastatic workup?
There is 5 mm nodule in the left lung, sir. They have not given whether it is metastatic, sir. Too small to look for the features of metastasis.
Then how will you confirm that? Because you have to plan for surgery. No, the moment it becomes a positive, you are altogether your management differs. Okay.
Yes.
Then what is the investigation you would like to have in this case to look for?
Sir, has the lung nodule is very small. I would and the features are not cannot be assessed based on the size. I would consider it as LABC and go for new adjoint.
No. When the solar chest has given as some nodule is there in the lung, so we have to take it as a metastatic until proved otherwise. It makes a lot of difference in this case. Any other investigations or modality of investigations you would like to use in this case?
The PET CT. But
Yes.
still
Though PET CT is not one of the commonest armamentarium in the management of the metastatic workup, but in still case, if the CT chest shows that some suspicious nodules are there, whether it is a PET avid or PET non-avid, these are the classical indication for PET CT in case of a carcinoma breast. Does it give 100% all the times?
No, sir.
What is the mechanism of PET CT?
So the tumor cells, fluorodeoxy, more active tumor cells will eject radiation that will be picked up by the PET CT machines. If there are osteomyelitis or any infectious conditions, that also will be picked up and false positive.
Overall breast metastasis, is it a PET avid or PET non-avid?
Sir?
Certain metastatics are there. They are not biologically active. They doesn't secrete this what you said 5-fluoroxy enzymes. No, it will not be there in all the tumors.
Yes.
Okay. So is it the breast also is more of it secretes. Okay. Yes. So probably chances of getting the positivity in case of a breast metastasis by PET CT is more. So it is a PET avid, you have to call it as. Okay. So there are two options in this case, whether it can be positive or negative. My question is, if it comes as a negative, what will you do?
Then there is no metastasis. We'll consider it as LABC only, sir. Give neoadjuvant chemotherapy, then downstage the tumor, and if any micrometastases are present, that will be treated by chemotherapy, neoadjuvant chemotherapy. After 3 cycles, go for mastectomy, modified radical mastectomy. Then
if it is shrink significantly, more than 2/3, so why not breast conservative surgery in this patient?
Sir, not required, sir, because
in other words, what are the indications for breast conservation surgery?
The size of the tumor, if it is less than 5 centimeter, then patient
when you are planning for neoadjuvant, the size doesn't come at all. The breast conservation is not based on the size of the tumor. Okay.
Yes. with
There are contraindications are there. Okay, the multicentrality, multifocality, center compartment involvement. These are all few of the relatively involvement of contraindications. But in this case, if it responds very well to your neoadjuvant chemotherapy after 3 or 4 cycles, if it shrinks significantly, there is still options of wide
breast
local excisions. Breast consolidation is still possible. You continue the remaining part of the cycle. You cannot rule it out, the possibility of a breast
Yes.
consolidation in these cases.
Yes.
Okay.
Dr.
Yeah, what do you do
Sushmitha will
next?
also, Dr.
Sushmitha, there
Sushmitha,
are a few questions from the audience.
Yes.
Dr. Nas madam is
Please take
asking you whether Krukenberg tumor is common in this age group.
No,
If
sir.
no, yeah, why? If yes, why?
Krukenberg is seen in premenopausal women who has active ovulation. She is postmenopausal, so it is unlikely.
good.
Good. Yes.
You said the
Sir,
neoadjuvant chemotherapy. How do you base your chemotherapy regimen in this case?
Chemotherapy regimen.
How do you base? Because there are many options are available. No, many drugs are there. Different groups are there. Anthracycline groups are there. Taxanes are there. So many are there. So how do you base your chemotherapy regimen in this case? What is the criteria?
So first we'll use like latest anthracyclines,
Why?
taxane.
Why anthracycline? What is the rationale?
So there are like adriamycin has the side effects, cardiotoxicity.
Okay, you evaluate. Evaluation of the patient is a mandatory. Whenever a patient subjecting on a chemotherapy, you have to look for the 2D echo, ejection fractions, all these things you look about. Lung fibrosis, all these things has to be assessed, no? When you're
Yes.
planning for the chemotherapy. If for their sake, patient is okay, doesn't have any other comorbid conditions, you can use any chemotherapy. How the chemotherapy is based?
First we'll start with chemotherapy, so then we'll see the response, sir. If patient is
Which chemotherapy? Which chemotherapy decide? What is the rationale of using the chemotherapy? I'm asking.
Cycle. Not sure, sir.
No, now in these cases, you have to depend on the report of a ERPR status and KI proliferative index and other things, because they give the pathological staging of the disease. Okay, if the patient is having an ERPR positive, HER2 negative, they have got a favorable prognosis, you know?
Yes.
Okay, in this case, don't start with the aggressive chemotherapy. These are the patients that have a favorable outcome. Starts with an anthracycline therapy. Keep these taxanes reserved for further mode of therapies.
Yes.
The clinical studies have shown that response in the ERPR positive patient with anthracycline is slightly better as compared to the taxanes. Taxane as a first line of chemotherapy is selected when the patient is having all the risk factors in the form of ERPR negative and HER2 positive. In such cases, the disease is very aggressive. In those cases, you can target the cells with the straight away with the taxanes. So on this basis, your chemotherapy regimens are usually based. Apart from that, if the lung fibrosis is there, ejection fraction is less, comorbid conditions are there. Even then, such cases, you have to avoid the drugs which are cardiotoxic or the lung toxics.
Yes.
Okay, what do you do next? Okay, please carry on.
So we have actually the time is up. So would you?
Yeah, please, we can conclude, I think.
I think both the physics are fairly done well. What, Sharad sir? You are a senior person.
Yes.
You should comment about that.
No, sir. I think I agree with you. I think it was a good discussion from everyone's perspective, as an examiner perspective and postgraduate perspectives both together. Thank you, everyone.
Thank you.
Thank you. Thank you.
Thank you.
Dr. Nagraj Bhalki, could you please?
Good evening, everyone. Namaskara. Before giving a vote of thanks, I think every time when we listen to these panel discussions or examiners, new thing which I have learned, the skin involvement, what Ishwar sir has told about the skin involvement, that it doesn't take for the staging. So that's a good take-home messages. A lot of things which we have learned today. Thank you, all the three examiners, Basheer sir, Sharad Tanga sir, Ishwar R Hosamani sir. Special thanks to Madam Nas Madam considering me to be a part of this panel discussion. I think all the credit goes to for this session, Shilpa ma'am and Survey sir. Thank you one and all. I think next time the PGs, their contribution should be, we need to work on this. The attendance is on the little lesser side. We'll see to that next time the number of students will be more. Thank you. everyone.
Yeah, thank you, Nagraj Bhalki.
Thank you.
Thank you, sir.
Hello, thank you, Nagraj Bhalki. I request Dr. Nas
Yeah.
to make comments.
Yeah.
Hemant.
Thank you, Dr. Sarvesh. At the outset, I would like to thank Dr. Sharad Tanga, Dr. Ishwar Hosamani, and Dr. Basheer. All the students have done very, very well, both the students, really, actually very well. And there was a lot of learning from our side. We really, every time we attend all these meetings, I think we seniors are attending these like case discussions and most of these discussions because we feel the learning never stops. So I feel all the postgraduates should motivate each other because there's a lot of effort put into conduct these programs. See, I think Dr. Shilpa has come running from her busy schedule. Dr. Nagraj has run. I heard Dr. Ishwar Hosamani run back to his house within and each one of you, all the examiners, also have to do a lot of preparation. So I think there is so much of effort put in. The postgraduate should understand this is for them, and they should start participating in this. That is a humble request from our side. And thank you all for Dr. Basheer, Dr. Ishwar, and Dr. Sharad Tanga sir. Thank you very much for being the examiners. And thank you, Dr. Shilpa and Dr. Nagraj Bhalki for being the moderators. And
Thank you, madam.
thank you everyone for participating.
Thank
you.
Thank you.
Thank you, madam. I request Dr.
Very thanks to Chairman Nas, ma'am, and Secretary Aras, and moderator today is Shilpa. And then my co-examiners, Dr. Sharad Tanga, good friend of mine, and Bashir is a really good interaction.
Thank you very much.
I think
Thank you
thanks
so much.
to all.
Thank you, sir. Thank you so much. Sir.
Thank you so much.
Thank you, man. Thank you.
Thank you.